Sir, I'll get it started. We have about 20 participants already joined. So others will keep joining, I believe, right? So it's already 7:03. Yeah. So good evening, one and all students as well as faculties and team INEOs who are joined for today's the second topic of the Impact PG program. So we are very happy to once again conduct the second program today. In fact, we started our first program last week on the last Saturday, and we have decided to conduct it on every Saturday by 7 p.m. So I'm sure you're all aware that we do have a group created to keep a constant updation on the program. So we would request you to join and get the constant update. So coming to today's topic, the case discussion is on acute ischemic stroke. I'm very happy to welcome the senior examiners, Dr. Sujit Thomas from Tiruvalla, as well as Dr. Uni Krishnan from Kollam. We are very happy to welcome you, sir, as part of our INEOS supported program for this Impact Page. Thank you very much for sparing your time and joining us today for the case discussion. I'm also equally happy to welcome the two examinees, Dr. Anupam S. Thomas and Dr. Shalini Nair. Thank you very much, madam, for joining us today. I'm sure this case discussion is going to really help you clear your examinations. So looking forward for an exciting discussion today. So I also thank all the participants who are participating from in today's event. I'm sure each and every one of you would get equally benefited out of this program. And post this program, we are also planning to get this uploaded in the YouTube for sure. So all the discussion will be much relevant to you. But yes, it's nothing like online attendance. You can always post any queries, questions. You can also post in the chat box, which will be taken by the senior faculties. I also welcome Dr. Matthew Pulikan. Thank you, sir, for joining today's program. So looking forward for today's program. So I now hand over to Dr. Sujit Thomas to take it forward from here. Over to you, Dr. Sujit.
Yeah, thank you, Raja. Good evening, all. First of all, I would like to thank the organizers for that Impact PG for such a beautiful academic juncture for the PGs who are preparing for the exams. And as you all know, critical care has only maybe important 20 to 30 cases, which almost all the PGs will be knowing the practical aspect. Only thing is from the exam point of view, they require a little bit fine tuning. So your program will be much helpful for the same, because the most of the cases will be dealt with in this coming weeks. So I would like to welcome Dr. Anupam and Dr. Shalini. The examiners. This is just a review of the things. Most of the things you will be knowing. This is just a review of, or maybe some things which are important for the exams. And next, I would like to invite Dr. Unni, my co-examiner, and he will start off the session with the slides. So I think we can start off.
Yes.
Yes, sir. Please go ahead.
Yes. So we all know. Good evening, friends. We all know the case we are about to discuss is on acute ischemic stroke. So I hope Dr. Shalini and Anupam has attended the prior session by Dr. Murali and Dr. Kiran. I think we are also following that format only. I'll be presenting a case, and based on that, I'll be directing questions to you. Okay. So if you know the answer, you just tell it, and after that, I'll tell you the evidence or the answer for the same, and any other discussions we can discuss it later. Okay. Sundar, can you share the slides, please?
Yes, sir. Sure. Just.
Next slide, please. Next one.
സൈഡിൽ പോയ ഒരു പിന്നുണ്ട്.
Slide. So we have a 60-year-old male who was brought to ER at 10 a.m. Yesterday.
Sir,
it was yesterday at 10
Sundar,
a.m.
can you just put it in full view? Full PowerPoint? Sundar?
Yeah. Sir, just.
Next slide. So, hope I'm audible.
Yes, sir.
So we have a 60-year-old male who was brought to ER yesterday at 10 a.m. with complaints of sudden onset of right upper and lower limb weakness, which was associated with tingling and numbness.
So you're not audible
Only,
now.
only
Not audible now, sir. Mute.
Only you are muted.
Sir, now you are on mute mode, sir. Me, sir, you are on mute.
Okay. He woke up from sleep at 6 a.m., was apparently normal, developed symptoms at 8 a.m. and reached the hospital by 10 a.m. 2-hour gap. Okay.
Sir.
He developed sudden onset of giddiness followed by difficulty in speech, which was followed by the development of the right-sided weakness.
Yes.
Subsequently, he was unable to walk and had facial weakness, which was persisting. There was no history of headache, seizures, fever, or vomiting. Next slide. His comorbidities included, he's a non-diabetic for the past 5 to 8 years and is on OHA, which is metformin. And there is no past history of any coronary artery disease or cerebrovascular accident. And his father has actually died of acute MI when he was at the age of 55. Next slide. Personal history. He's a government employee, mainly does office work, non-alcoholic, non-smoker, is a non-vegetarian by diet. Next slide. And on examination, the Glasgow Coma score was 11, E2, V4, M5, drowsy, arousable, and following commands. He is able to protect the airway. Pupils are reacting well bilaterally, and slight hemiparesis, grade 1 power in right side, both upper and lower limbs, and full power in the left side of the body. Next slide. So he had slurring of speech with transcortical motor aphasia on examination, right-sided facial palsy with deviation of mouth to left side. Deep tendon reflexes were mute on the right side. There is no blurring of vision or nystagmus. And sensations, reduced touch sensation on the right side with no loss of temperature or pain. Next slide. Okay. Dr. Shalini, can you summarize the case?
This is a 60-year-old male with a background history of diabetes mellitus, who was apparently normal till 6 a.m. Symptoms of right hemiplegia started at 8 a.m. Right hemiplegia with slurring of speech, and they presented to the casualty by 10 a.m. And on examination, the GCS was 11 with the right hemiparesis and facial palsy to the left and deep tendon reflexes absent on the right side.
Okay. We'll proceed.
Wait. Dr. Anupam, could you please, I think history, Dr. Unni has mentioned some points. I think, do you want to ask anything more in the history or in the clinical examination? You want to perform something else? Anything more relevant in history? What are the main things in history? If you have someone coming with a weakness when he woke up or something like that, what are things you have to ask in the history specifically, and what all things you will examine?
When was the last well-known time? Just
Okay.
one history. Then
So this in this case, he woke up at 6 a.m. And 8 a.m. If he woke up with a stroke, what is the last well-known time? Last known time.
wake up stroke, then we do not know the last well-known time. That is called a wake-up stroke.
So which time would have you would have taken?
Then we can ask whether the patient, the person who is being there with her, like ask a leading question as, has he ever woken up and gone to the bathroom or something like that? Otherwise, the last time when he was known.
So it should be, yeah, correct. It should be around 10 p.m. itself. Yeah.
10 p.m. when he went to sleep.
Yeah. Okay. Okay. Then one thing is the last known well time. Then next, what else? Only can you go back? Sundar, can you go back one slide? The history part.
Just a minute.
Okay. So you can proceed. What else you want to ask?
History of headache, vomiting.
What is the significance of it? So basically, whenever you present a case, you will have to be like you will have some DDs after the history. After that, you will examine. Then you will cut down on the DD. So what all things you will be seeing in your like history, important things. One thing you were told is last known time. Then you ask for the history of vomiting.
Headache.
Yeah, what is the significance of it?
Vomiting and headache can be like it can be a hemorrhagic, can be due to a hemorrhagic stroke, or we have to exclude all the stroke mimics, like even a migraine can present like that, or meningitis.
Okay, fever. You told.
Fever.
Okay. Yeah.
So leading questions that can exclude the stroke mimics.
Another important thing is seizures.
Seizures.
Okay. Okay. Seizures. So what else you would ask the history, like was there any posturing, or did he like was there any urinary or bladder incontinence or bowel incontinence? Okay. Then something in the history other than not in the presenting complaint, but maybe in the past history or something.
Previous history in the past, similar history ever in the past, or a recent weakness, headache.
Okay. Okay. Past history of
Diabetes.
Okay. The risk factor. Yeah. Okay. Then anything specifically? One more thing, cardiac.
Cardiac illness.
For any cardiac history. Okay. Then the personal history, everything he told smoker. Yeah. Then
not a smoker.
Yeah.
Thanks.
Okay. Then in the medication, anything relevant history you have to take when you take
Oral
history.
anticoagulants.
Oral anticoagulant intake,
Antiplatelets.
antiplatelets,
Antihypertensives.
regular
Oral hypoglycemic agents.
Okay. Basically, you want to ask about the oral anticoagulants specifically. Okay. Okay. Unni, I think we can proceed.
Yes, sir. So the systemic examination was done. So even though the GCS was 11, the airway remained patent. Breathing at a respiratory rate of 20 per minute and bilateral good air entry. Circulation was reasonably okay. Heart rate of 76 per minute. BP 140/90. ECG showed sinus rhythm. No murmurs. He was afebrile. General examination, no pallor, icterus cyanosis or any nothing like that. And the abdomen was soft and non-tender. Next slide.
Yes.
A point of care sugars was done, which was 160 milligrams per deciliter. Next slide, please. And the blood gas remained normal with the normal lactates. So, Dr. Shalini,
Yes,
what are your differentials at this point of time?
It can be my first differential would be an ischemic or a hemorrhagic stroke.
Okay, tell each of your differential and why you say so.
Yeah, as per the history and the clinical examination, why you told so?
Why you told that this is a case of stroke?
Because
So first you told acute ischemic stroke, first DD. What are your points for it and against it?
And it was
It's not like both of you
right-sided.
can join. Both of you can join. It's not like
Yes,
we're
sir.
asking the name, but anybody
Yes.
can tell it. Okay, yeah.
He started with the right-sided weakness. With he had aphasia and he had slurring of speech. And there was an examination also weakness facial nerve palsy was,
and the right-sided
hemiplegia was
that is in favor of a stroke,
ischemic stroke. But he didn't present with any headache, vomiting, so against an ischemic, hemorrhagic stroke.
Then it can be we have to rule out a metabolic encephalopathy for him. So all the
wait. Then his BP is mentioned as 140/90.
Encephalopathy.
Within normal limits.
It is normal limits, so maybe not a hypertensive encephalopathy.
Okay.
So your
metabolic can be a chance. Metabolic
differential is the stroke. Second is metabolic encephalopathy.
Metabolic encephalopathy.
Third,
even sepsis needs to be ruled out in this patient.
See, there is no history of fever, vomiting. He's a relatively younger male with only diabetes as a comorbidity. So, are you suspecting any hypoglycemia or infection in this case? And it's a sudden onset. Otherwise, well-to-do male present with a sudden onset weakness. So, after stroke, second differential has to be some other thing.
Intracranial neoplasms.
No, it should be IC bleed.
Hypoglycemia.
Hypoglycemia has already been 160.
160 was the sugars, and he's not
second
diabetic.
DD, yeah, second DD I think is should be
motor.
Second should be IC bleed.
IC bleed. Yes, sir.
Yes, sir.
Okay.
Yes,
so I think lots of confusion. I think maybe one of you can speak when two people. Okay, so first you told is acute ischemic stroke. Second DD is probably a intracranial bleed. So what are your points against intracranial bleed as per history?
The BP is, there is no history of headache. No history of headache or seizures. The BP is normal, and also generally the intracranial hemorrhage, there is acute onset. The presentation is, and in contrast to a ischemic stroke, which has got a dense like motor weakness, the progression is slow in case of an intracranial hemorrhage. Weakness will be slow, which progresses to a greater weakness over time.
Usually a headache and a vomiting, which then progresses to a neurological deficit.
And pupils are equal.
Pupils are also
equal and reactive in this patient.
Why do you want to differentiate between an ischemic and an hemorrhagic stroke? Both are strokes, right? Why do you
The
want
management differs. There is a timeline for
because the management is entirely different for both.
entirely different in both of it.
So what is the third differential? Hypoglycemia, metabolic encephalopathy are all stroke mimickers. We can't say
yes.
the differential.
Mm.
Third differential.
In space occupying lesions.
It could be an intracranial space occupying
lesion. First presentation.
So that can present with, what is the presentation of an intracranial space occupying lesion?
Seizures, headache.
Yes, any features of
Weakness.
raised intracranial pressure. Headache, seizures, projectile vomiting, papilledema.
Sometimes they will have a history of prior some headache and all, which would have been evaluated, and now the worsening could be due to maybe increased. There could be hemorrhage or increase in the edema or increase in the size of the lesion. Yeah, correct. Okay.
Fourth differential.
Motor weakness for him. We need to rule out a
motor neuron disease. Motor neuron disease.
Like a Guillain-Barré.
Guillain-Barré presenting with hemiplegia.
Guillain-Barré ascending paralysis starting from lower limbs.
Yeah.
This is unilateral, right?
Yeah. Bilateral. Yes.
So Guillain-Barré will never come into this picture. So what is, shall I say?
Yes, sir.
What is TIA?
Transient ischemic attack.
Can you define it?
It's a weakness which persists for 24 hours and then there is recovery after the 24 hours.
Lasting less than 24 hours.
That was the old definition. What is a new definition for TIA? The old definition was weakness that develops over a period of 1 hour and resolves completely back to full recovery in less than 24 hours. What's the new definition?
Sorry.
According to there is no timeline attached.
Okay.
There is no timeline attached to the new definition of TIA. Is this a TIA? How will you say clinically whether this is a TIA or is a stroke?
The weakness has to recover.
No, there's no time.
There's no time gap. So we can.
This has to recover. Okay. So what are the risk factors for a patient to develop stroke?
History of hypertension.
We can classify into modifiable and non-modifiable. Modifiable and non-modifiable. Tell me answer, please.
Non-modifiable is age, sex.
Age above?
60 years.
60 or no? Is it 60?
Not sure, sir.
Dr. Anubhav?
65 years.
Age more than 65 years.
Male sex.
Why male sex? Actually, the reason they are not mentioned. We also don't know why males are more affected with stroke. Okay, age, male sex, followed by
family history.
Family history. African descent. Why African descent? Because they often have high BP. Okay, what are the modifiable risk factors?
Diabetes, hypertension, sedentary lifestyle,
smoking,
alcohol.
Yes. Okay, so sir, do you want to take over?
Okay, then next AD, I think you had already mentioned. One is hypertension and encephalopathy, but in this case, the BP, everything was normal. And normally they present with something like press-like symptoms, like they may have some seizures or some vision abnormalities, which is not there. Then next could be migraine. I think there is something called hemiplegic migraine and all, which presents like this. So migraine is under DD, but he doesn't have a previous history of any, or there is no aura or anything. So migraine can be ruled out. Then I think almost all then meningitis as you told, but no fever, everything. And okay, the clinical examination part I'm not going into because this like will many more things to go into it. Only thing is in systemic examination is you have to look for anything like in the other system, anything. Anupam, can you tell? Like in the other system other than the CNS already discussed. In the other system, anything specifically to be looked for?
In the cardiovascular system, we have to look for when we assess the pulse rate, if there is AF or there is any evidence of murmurs suggestive of an endocarditis.
Murmurs, arrhythmias, and then look for any carotid bruit also.
Carotid bruit, yes.
Okay, to look for any like thrombotic. You'll be knowing, no, it has two, embolic and thrombotic. For ischemic stroke, two parts are there. One is embolic or other is thrombotic. So look for thrombotic. See any carotid disease, look for carotid bruit. Okay, Uni, you can proceed.
So the patient is complaining that patient feels like a curtain falling in front of his eyes. Curtain falling in front of his eyes and losing vision. What is that known as?
Hemianopia.
Bilateral. Both eyes. What is the symptom due to? That is a form of TIA affecting the ophthalmic artery.
Okay.
Because of atherosclerosis in the carotids, it spreads to the ophthalmic artery. That is called amaurosis fugax. That is a form of TIA.
Yes.
So TIA can occur due to any blocks in the mainly in the carotids or any in the cardiac and all. Okay.
Yes.
I think the slides. Can you move the slides, please? Next slide. Next slide. So the sugars 160, ABG was normal. Next slide. The differentials we just mentioned. Next slide. The investigations, the renal functions were normal. The complete blood count, hemoglobin 13, WBC count to 11,000, platelets 2.5, LFT within normal limits, INR of 1.1. ECG showed sinus rhythm. 2D echo was within normal limits. Next slide. So these are the points we are going to discuss today. What is the approach to acute ischemic stroke? What is the role of thrombolysis? What is the role of endovascular therapy? The usual general intensive care management, and how will you manage malignant MC infarcts? Next slide. So, can you tell me about the intensive care management? This patient, a patient has been, you are seeing the patient in the ER. How will you proceed? How will you manage the BP, sugars, saturations? When will you intubate? You can answer in detail.
Mainly 3 goals of management is there.
Yes.
One, initially I'll have to stabilize his airway breathing circulation. And since it's a primary brain injury, I would like to prevent a secondary brain injury from happening. And third is, I should get if I'm planning for any reperfusion strategy, I have to do it within the respective time. So those would be my initial goals of therapy.
Okay, you can continue. How will you, what
you can explain. You can explain. Yeah, each one. Told A, B, C. So this patient, I think, is aphasic. So how will you proceed?
Yeah, but the case had told that his airway was patent. Like there is no evidence of any bulbar dysfunction, swallowing or pooling of secretions. So currently his airway seems to be okay. So airway is a patent. As for breathing part, I'll monitor the saturation. If the saturation is less than 94%, supplemental oxygen will be given. And stabilization of the cardiac. It depends on whether we are BP. His BP is 140/90 millimeters of mercury. So his pulse rate is also normal, so which is acceptable for him. Then other priority in the ED is we have to
for the GRBS.
GRBS has been checked. The NIHS score needs to be calculated, and then if the patient is within, we need to shift him for the imaging and rule out a bleed, and then initiate IV thrombolytics for him, and
He's within the 2 hours window period, and clinically it is a stroke. So I would like a non-enhanced CT scan to be done so as to rule out intracranial bleed.
And other measures to avoid the secondary
Injuries.
neuro include avoiding hypo or hyperglycemia, avoiding hyperthermia,
avoiding fever, avoiding seizures,
heading neutral position, maintaining normocapnia, normoxia.
So in the ER, the BP recording came out to be 200 by 100.
This patient is a candidate who is whom I can plan for thrombolysis if the CT is not showing an IC bleed. So ideally, a pre-thrombolysis BP has to be kept 185, 110.
So what drug will you give to control the BP?
The first drug of choice would be labetalol. Labetalol 10 to 20 mg IV, which can be repeated every 10 minutes. And
how
then
many times will you repeat?
Sir, up to
maximum 300 mg.
In 24 hours.
24 hours.
I'll give 10 and then 20 up to a bolus of 80 milligram can be given and then start him on an infusion.
Infusion of 2 to 8 mg per minute.
Because it is easily titratable, I can stop the drug.
Okay.
Yeah, okay, good. Only thing I would like to add is whenever in the exams such a questions comes like as I told, you have to go by ABC. Next thing is whenever we have to attach the monitors, you told you will look at the saturation. You look at the saturation BP. You put in like 2 18-gauge cannulas. Draw the blood for what all things you want. So you are suspecting stroke. So what all you will need a CBC, PTPT, INR, the sugar. But we need not wait for his report, but still you can take the samples for so and so things, and then okay, then BP you told, okay, fine, okay.
Suppose the patient develops have a temperature of 102 Fahrenheit, what will you do?
I will have to give paracetamol and try to reduce the temperature.
You'll use paracetamol.
Yes, I need to control
We have to aggressively control the temperature.
Okay. Next slide. Actually, you have answered most of the questions. The saturation you need to maintain more than 92%. And if the airway is not protected, you have to secure the airway. Patient positioning, I think you didn't mention. You have to
30 to 50.
You have
neutral position. Neck in the neutral position.
Yes, head in by 15 to 30 degree so that ICP is reduced. And cardiac monitors have to be attached because cardioembolic stroke is a very common cause, and even with brain-heart interactions, the patient would develop ECG changes. And arrhythmias are most frequently associated with insular strokes. Next slide. In regards to temperature, hyperthermia can occur in 1/3 of patients, which could be seen, and treat fever and infections. And there is no evidence for cooling. There is no evidence for hypothermia in stroke management. And target sugars in the range 140 to 180 milligrams per deciliter. What is the rationale? What is the problem if patient develops hyperglycemia?
Hyperglycemia has been shown to have an increased incidence of bleeding. So poor outcome in stroke.
Risk of hemorrhagic transformation.
Hemorrhagic transformation is high.
Okay. Next slide. The BP management also, I think you have mentioned. Twice you can repeat the labetalol bolus. And why not NTG, nitroglycerin?
It produces cerebral vasodilatation. So it increases the perfusion as well as ICP gets raised.
Can you just have say a brief description about the cerebral blood flow in a normal brain as well as an infarcted brain?
In a normal brain.
What's the normal cerebral blood flow? How much volume or percentage of cardiac output goes to the brain? And what is the normal cerebral blood flow? What happens when the patient develops ischemic stroke?
65% of the cardiac output goes to the brain.
65% of the cardiac output goes to the brain. 10 to 20% of the cardiac output goes to the brain. And what is the normal cerebral blood flow? It is around, do you know?
Cerebral blood
flow.
Normal cerebral blood flow.
120 ml per
120
minute.
to 150 ml per minute.
It's around 50 to 60 ml per 100 gram per minute, 100 gram brain tissue per minute. If it falls to less than 20, it is at risk, and less than 10 is severely hypoperfused, high risk of stroke. Okay. Next slide. And in acute ischemic stroke, you have to reduce a PP only at what range?
Less than 220, 120.
It's not for thrombolysis.
Yes. Okay. Next slide.
So, 1 second. So, in TAA, what is your target?
Yeah.
So TAA, what is
target
of BP?
We will not reduce the.
Can keep it as.
We will not reduce the blood pressure in TAA because.
Okay.
The cerebral penumbra is getting perfused because high blood
basically
pressure.
TAA, there is a chance that TAA can progress to stroke. So yeah, so you keep your BP slightly higher side, correct? Don't reduce the BP because you have to consider it like a case like who has not been stroke, which has not been thrombolyzed.
Yes, sir. Yes.
So how will you assess whether this TIA will progress to stroke? Is there any scoring system for that?
The ABCD score.
Yes, ABCD2 score. Can you just expand it?
Age greater than 60 years.
1 point.
Blood pressure greater than 140/90.
Yes.
C, clinical features, either involvement of stroke or weakness. Weakness gets a point of 2 and speech a point of 1.
Okay.
And D is this diabetes
duration
and duration.
Duration less than 1 hour is 1, and greater than 60 minutes 2.
60 minutes is 2.
What
so high risk TIA is less than
greater than 4. The score greater than 4. High risk TIA.
So high risk TIA has a higher
chance of going to stroke.
Okay, good. So coming back to the case, what is the best next step in this management of this patient? We have.
So though we asked in between regarding some questions, as per I think after the initial assessment, IV line, you send for investigations, and the next step is you have to assess. You told something regarding the NIHSS.
Yeah.
Okay. So after that NIHSS, okay, NA is a like scale from 0 to
42.
0 to 42 is the maximum score.
Yeah. Okay. Then the next step after that much thing is over. What is the next step? Most of the hospitals will have something like a stroke code also, which is activated by the ER people when the patient comes with stroke. The initial part itself, they will be announcing. Somebody comes with hemiplegia, they will call for a stroke so that they will get the help. The whole thing is done to reduce the time for the till the IV thrombolysis. So till now the IV secured everything. As the NHS code, the next step is to do a
go for imaging.
Yeah. Okay. Which image?
Yeah, since it's clinically, we have seen that it's a stroke, and my time period also, I'm within the window period. I would like to go for a non-enhanced contrast CT to rule out bleed. Because an MRI will take much more time, and sometimes by the time the window period may cross. So I need that window period. He's already in the window period.
So in this patient, you prefer CT rather than an MRI?
To save the time, because clinically it looks like a stroke.
So since the patient is in window period, you would like to have a plain CT or a CT with the contrast.
What is the problem with plain CT? That is what Dr. Uni is asking.
Vessels cannot be assessed. So
why you want to assess the vessels?
So large vessel occlusion, if present or not, cannot be identified in plain CT.
Okay.
But here in this case, according to protocol, we can go ahead with either a non-contrast CT or an MRI.
Okay.
In our institute, generally, we do an MRI. Especially if the patient is presenting within 2 hours.
Actually, for this patient, a CT with CT angio is needed, no? Only is needed because the patient is in the window period. And you can save my time is brain, right?
Yes, sir.
It's in the window period, and CT with CT angio, plain CT, you suppose you plain CT came out to be normal.
Oh.
And CT angio, there's a clot in the M1. How will you proceed? Plain CT is normal, and you have a clot in the CT angio done. You have a clot in the M1.
So plain CT is normal. I will go ahead, go ahead with thrombolysis followed by mechanical thrombectomy.
Why can't you straight away go for mechanical thrombectomy?
Trials.
So the answer for this question is
early strokes will not be
Early
seen
strokes
in
may
the
not be seen on a
CT.
CT.
You have 4 options in this question. Is it 2 or 3?
We'll go ahead with IV thrombolysis followed by mechanical thrombectomy.
Okay. Why is that so?
So CT early strokes will not be.
So sometimes subcortical lesions, posterior lesions may not be seen in a CT.
CT is not as sensitive as an MRI. And also there are trials which have compared IV thrombolysis followed by mechanical thrombectomy, which is
had a good outcome.
Okay.
Yeah, there is a catch in that. Actually, many institutions will have their own protocols.
Yes.
But as per the evidence, like as you told, many studies show that the IV thrombolysis followed by mechanical thrombectomy is good. But the problem is it will delay your mechanical thrombectomy.
Yes.
Some people in some home institutions, what they do is they give half the dose of thrombolysis of tenecteplase or something like that, and then they take him for a thrombectomy. But some places they give full thrombolysis and then take for a mechanical thrombectomy, because if the large vessel is occluded, most of the times IV thrombolysis won't work. So they have to go for a definitive therapy like mechanical thrombectomy. So the evidence is like that, but there is a problem with that. If M1 and all, as Dr. Uni had told, is affected, it's better to always give more preference for your mechanical thrombectomy rather than IV thrombolysis. If you are distal M2, M3, something like that is involved, maybe IV thrombolysis followed by mechanical thrombectomy is an option. So that depends on your hospital to hospital and your competence of your interventional radiologist and your interventional neurologist. So as of now, you can tell like IV thrombolysis followed by mechanical thrombectomy could be an option. Okay.
So you decided to proceed with thrombolysis. How will you proceed?
Yes, sir.
How will you proceed?
I need to control the BP. So BP needs to be less than
185
by 110 millimeters of
before
mercury
thrombolysis.
And
I have to rule out any contraindications also. In this case, PTNR, all investigations are normal and there's no other clinical history suggestive of a contraindication.
And there is no previous history of IC bleed or.
Do you want to have a PTNR?
No, sir. No. We do not want to have a PTNR.
Okay. What are the inclusion?
What is the most important test which you need before thrombolysis?
Most important test before test.
Yeah, only one test is required. You should rule out that the patient doesn't have hypoglycemia. Rest the investigation. Rest let the other investigation take time. Unless the patient is on NOAC or something like that, you can go proceed with if the investigations are delayed.
Yes, sir. We will not wait for the investigations to come. We'll go ahead with thrombolysing after controlling the BP.
So what are the inclusion criteria and exclusion criteria? Can you just brief it out?
Inclusion criteria, basically patient coming within 3 hours of onset.
Age? Age. Age.
More than 18 years.
Any cutoff, upper cutoff?
Less than 80 years.
Yes, 18 to 80 years.
8 years.
Yeah, one person can tell. That will be better. Yeah.
One person can tell. NIHS
score less than
25.
Okay. So will you thrombolyze a patient with NIHSS of 2?
No, sir. We
No.
will not thrombolyze the patient. Less
Why?
than 6, we will. That is a minor stroke. Patient will be able to live with it. So we do not want to subject him to if it is not disabling.
Yes, you said that you will thrombolyze if NIHS is less than 25.
6 to 25.
6 to 25.
Okay, so and less than 5 is could be a TIA also.
Yeah.
Yes.
Okay.
Yeah, as you told regarding that, if it's low, doesn't mean that you can't thrombolyze. If the symptoms are disabling, because many studies have shown that those patients they had higher rate of like dependence and all. Like patients were not able to walk, they were dependent with an NHS score less than 5. So that is a clinical call. If the patient's symptoms are disabling, you can still go ahead. That depends on your neurologist, and your clinical assessment.
Yes, that is more of subjective. If the patient happens to be a teacher who frequently needs to lift his arm to write on the board, that is subjective importance for him. So even if the NHSS is less than 5, you can thrombolyze. Okay.
So NHS score, age,
and the involvement of the lobe. If usually more than 1/3 lobe is involved, then
we do not go ahead with thrombolysis.
Okay. Next.
Extended thrombolysis contraindicated in contraindicated in patients with DM or prior TIA, age greater than 8 years, and multilobar
PTNR greater than 1.7 when on anticoagulation.
So these are the contraindications
for an extended period of 4.5 hours.
If the patient has received heparin.
Heparin before.
Therapeutic low molecular heparin for the past 24 hours.
LMW heparin for 24 hours. Unfractionated heparin for. Patient should not be receiving LMW heparin for last 24 hours and heparin for 48 hours. 48 hours. Unfractionated heparin 48 hours, LMWH 24 hours. Platelet count, any connection to platelet count? If you happen to have the platelet count,
1 lakh.
1 lakh.
1 lakh is the target.
Less than 1 lakh. And
ETNR less than 1.7.
Thrombolysis, if it's a cardiac course, cardioembolic stroke?
No, we will not go ahead and thrombolyze. Like evidence of infective endocarditis, we will not. Stroke due to and we will not thrombolyze.
If on the CT you happen to see a neoplasm, a tumor,
we will not.
Intracranial neoplasm is an absolute contraindication.
One kind of neoplasm you can thrombolyze. Intraaxial neoplasm you can't thrombolyze. Extraaxial neoplasm you can thrombolyze.
Yes.
Okay, then trauma, bleeding and all you mentioned, right? Any bleeding in the last 3 weeks? Trauma, surgery and all in the last 3 months. Sir, continue now. So, sir.
Okay, so regarding the thrombolysis window period, you told like 4.5 hours, right?
Yes, extended
to the ECAS 3 trial, it's extended up to 4.5 hours. NINS trial showed an extension of up to 3 hours.
Okay, so for decision purpose, it is 4.5. Okay, then this guy is young patient, no? And something regarding that NOAC. If the patient is on NOAC, you are anticoagulant. How will you proceed?
NOAC
oral newer anticoagulant. If the patient is on dabigatran or rivaroxaban or something like that.
For extended thrombolysis,
will you thrombolyze or not thrombolyze? So basically regarding that, NOAC is like if it is more than 48 hours, if the patient has not taken it for more than 48 hours, you can safely go ahead and thrombolyze. If it is less than 4 hours, don't thrombolyze. If somebody has taken it less than 4 hours, don't thrombolyze. 4 to 48 hours window is a catch. So there, I think depending on the clinical condition, you can thrombolyze. So below 4, don't thrombolyze. Above 48, you can thrombolyze. So between 4 and 48, take a call. Because if somebody is on newer anticoagulant, what test you would prefer?
Direct thrombin inhibitors, thrombin time we'll be looking into. And anti-factor 10A, factor 10A activity.
Yeah, both of it, it's not available or it takes more time. So, yeah. And somebody on warfarin, you told the INR less than 1.7, you can thrombolyze. Okay. So, any... Okay, no problem. Only you can proceed.
So you have done a CT scan, and what are the timelines for this timelines in stroke? Can you just NINDS timelines? Door to physician, door to CT, door to perfusion.
Door to ED physician is 10 minutes.
Okay.
Door to the neurological examination is 15 minutes.
Okay.
Door to CT completion is 25 minutes.
Yes.
Door to CT interpretation is 45 minutes.
Yes.
Door to thrombolysis is 60 minutes.
Okay.
And door to endovascular puncture is 90 minutes.
Okay.
Recanalization is 120 minutes. And to the stroke unit is 3 hours.
Good.
Okay, so this patient, you have looked for the contraindications, everything. He's a patient fit for thrombolysis. His investigations, okay, it came out to be normal. So you plan to thrombolyze. So how will you proceed?
Sir, early signs of neutral. What are the early signs on CT?
Early signs on CT for a stroke. Loss of sulcal gyral differentiation.
Loss of gray white differentiation.
Loss of gray white differentiation.
Hyperdense vessel sign.
MCA dot sign. Loss
Insular.
of papillar ribboning sign.
Insular. And a hyperdense dot MCA dot sign.
Sulcal effacement.
Sulcal effacement.
Loss of attenuation of the basal ganglia also. Okay, fine.
So any scoring system to identify the risk of hemorrhagic transformation?
Aspect scoring according to the CT, Alberta-Stokes scale.
Okay. Can you describe it?
It's the anterior circulation based on the MCA territory. Involvement of each territory, you reduce the score by 1. And in the posterior circulation also, we have the PC aspects where based on the thalamus, pons involvement, again, you are going to decrease the point by 1, and a point of less than 7 shows it's a severe stroke and ideally thrombolytic, more chance of a hemorrhagic transformation.
Okay, sir, please continue. So, sir.
Less of NHS and more of aspects is good.
NIHSS and aspects are inversely related.
So if NHS should be less and aspects should be more. Okay. This aspect score came as 7. So and NHS score you mentioned already. So and you look for the contraindication, everything. Your plan is to go for thrombolysis. So how will you thrombolyze? You have taken the the contraindication you have seen. You have took the consent of the bystanders or the patient, and now we are proceeding for thrombolysis. Okay.
We took an informed written consent from the bystanders, explained the procedure to the patient also. And then large bore IV cannula has been secured for the patient. 18 gauge peripheral IV cannula has been secured. And the patient is being monitored in the ED.
BP has been controlled. Yeah,
BP has been controlled to less than
below 185, 110.
Okay, so
and then my drug of choice is I will use alteplase at a dose of 0.9 milligram per kilogram, the 10% of which will be given as bolus, and the rest of it will be given in 1 hour. And during the procedure, monitor the BP, and if any hypertensive episodes, I will control. And if there is any seizures, stop the infusion.
Or any drop in GCS, and
stop the infusion and do
only
a
plan for
imaging.
So BP monitoring, you will in ICU you will be monitoring BP continuously, but as per the guideline, you will have to measure during thrombolysis. Initial 3 hours you have to measure BP. That is as per the guideline, 15 minutes. Yeah, okay.
15 minutes
so,
we will monitor.
So how does Altiplase work?
So recombinant tissue plasminogen activator.
So
it prevents conversion of plasminogen to plasmin.
Plasminogen to plasmin. So
Prevents
it prevents
fibrinolysis happens.
Okay. Okay, fine. It's a plasminogen activator. Okay, fine. Then you mentioned like Altiplase is the drug of choice. Why can't you go for Tenecteplase?
Sir, I told Altiplase because it is the drug which is approved for use
within the first,
and AHA guidelines also recommend it.
Yeah, Altiplase is recommended by the FDA.
FDA.
Tenecteplase is not approved.
Tenecteplase is not approved by FDA, but it's used extensively in Europe and Canada and in Indian subcontinent. So, what is the
for mechanical thrombectomy?
It can be justified if you're giving within 4.5 hours. There have been studies which shows that Tenecteplase is more superior, means better functional outcomes.
It's not like it's superior. It's non-inferior. It's non-inferior to in the first 3 hours. It's non-inferior to Altiplase. And you correctly mentioned if you are planning for mechanical thrombectomy, it is comparatively superior to your Altiplase. Earlier studies were showing high chance of bleeding with Tenecteplase, but later on studies shows benefit with Tenecteplase. Okay, so anything is okay. If we are planning for mechanical thrombectomy, then Tenecteplase could be an option. Okay. So Tenecteplase dose
0.25 mg per kg, maximum of 25 mg given as a bonus.
Okay.
Which is the agent being used in your institute?
Altiplase is used in our institutes.
Okay. The advantage
cost with Altiplase is also higher than Tenecteplase.
Yes.
Okay.
Cost concern, and the second is if the patient has around 4 or 10 minutes stay present, you can give it as a bolus. Within the window period, you can complete the thrombolysis with Tenecteplase. Actually, the ASA guideline 2019 recommends the use of Tenecteplase based on the evidence from pooled meta-analysis of 5 RCTs actually. It's non-inferior to Altiplase. Hemorrhagic transformation is less compared to Altiplase.
Yes.
Okay, can you have a word about the ECAS trials, ECAS 1, 2, and 3 trials? What is the difference between the three? These are the trials showing the evidence for
extended
thrombolysis. Can you compare? When was
three?
This
We know, sir.
We know only 3, sir, which extended the
period from 3 to 4.5 hours.
Okay, then say about ECAS 3. You should know how it progressed, right?
Yes. Yeah.
ECAS 1 95, ECAS 2 98, ECAS 3 in 2008. ECAS 1, why it failed? ECAS 1 showed high bleeding rates. Why? Risk of hemorrhagic transformation was high in ECAS 1. Why was that so?
Higher NIHS score and age greater than 80 patients.
The dose of Altiplase they used to set a higher dose. They used 1.1 mg per kg of Altiplase, and the maximum dose up to 100 milligram they gave. They came down to 0.9 mg per kg in ECAS 2, but still the timeline they kept at 6 hours. In ECAS 1 and ECAS 2, they took up to 6 hours, and ECAS 1, the dose was 1.1, and for ECAS 2, it was 0.9, and both these were corrected in ECAS 3. Can you tell me a brief about ECAS 3?
European trial where they extended the period from 3 to 4.5 hours.
Yes.
Certain except for 5 areas where they don't include age greater than 80 years, history of stroke and diabetes, a PTNR of 1.7, PTNR of 1.7, a multi-lobar stroke where the
MCA territory
more
greater
than
than
one-third is involved.
Okay.
So that was a population.
That was a population.
That
So
we studied.
Okay.
Unni, I think you can proceed. Only thing is MRI I think will come later.
Okay.
MRI,
Discuss about go to thrombectomy, right?
Yeah.
Okay. So you have thrombolized the patient, and as already mentioned, the angiogram you have done for a CT, right? CT angiogram showing a clot in the M1 branch of MCA. How will you proceed? Do you want to stop at thrombolysis?
Anterior circulation stroke less than 6 hours, you can go for a thrombectomy.
Okay. How will you proceed?
We will refer.
Interventional radiology team will be intimated. The stroke team will have interventional radiology also. Interventional radiology, interventional neurology, whoever. So multidisciplinary approach, they will be intimated. And
so our institution doesn't have, we'll have to refer them
the
to
patient to a center
where it is done.
So most of the strokes happen at night time. So you need to have a round the clock interventional radiology services. If you don't have that service, you have to immediately refer the patient.
Yes, sir.
So what are the trials showing benefit with thrombectomy? Can you say?
Anterior circulation less than 6 hours. You have the extent 1A. Then you have the Revascat, Swift Prime,
Mr.
Clean, which showed there were better functional outcomes in anterior circulation strokes involving the ICA and the proximal MCA.
Initially, first generation devices, a lot of trials were done with first generation devices, but they are proved no improved in outcomes. Actually, with the use of second generation devices only, they showed improvement in functional outcomes. Can you mention a few second generation devices?
Solitaire
retriever. It's 10 retrievers. One is solitaire. Second is?
Stent retrievers.
Second is Trevo. Trevo.
So basically, mechanical thrombectomy, you have to know the studies and plus this 6-hour window for anterior circulation stroke. And only thing which I would like to add is that is depending on the interventional radiologist or the interventional neurologist preference. Some centers do like clot aspiration and leave it. Some people do clot aspiration with the clot retriever. They're still using the stent retriever. So it depends on their expertise which to do. Like there is not much difference as per the evidence. Okay, so we can proceed to the next slide, I think.
I think just a note about what are Dawn and Diffuse 3 trials?
Yeah, basically, yeah, that will come to it. Yeah, basically, yeah, correct. So you told the window period as 6 hours. So
Yes,
extended mechanical thrombectomy time. Yeah. So that is studies. Yeah.
Dawn and Diffuse are the trials which extended the mechanical thrombectomy period from 6 to 24 hours for Dawn and
6 to 16 for Diffuse.
Diffuse 3.
In Diffuse 3, it extended from 6 to 16 hours, and based on perfusion imaging, they found out the penumbra and it showed better functional outcomes. While in Dawn, which extended from 6 to 24 hours, they compared the MRI volume mismatch and the clinical deficit, and that also showed better functional outcomes.
Better functional outcomes.
Yeah, basically Diffuse 3, 6 to 16 hours, and the ratio of with like they did with the seeing the perfusion studies. The core to the penumbral volume they measured in diffuse, and as you told, the other one, the core size and the clinical symptoms in the Dawn. So basically, they extended the window to 6 to 24. Same thing with thrombolysis also. There is something like till 9 hours you can extend.
Extend, right?
Yeah.
That also showed improvement in outcome, but it was prematurely stopped because of the
publishing of
So
the
basically, that is also regarding with the perfusion studies they did it.
perfusion studies.
perfusion studies.
Wake up also. Okay.
Wake up.
So, just a note about the stroke mimic. We know hypoglycemia is the most important mimic of stroke. So, hypoglycemia usually presents as loss of consciousness. Hypoglycemia, hyponatremia, hypoxia, hypoxic injury. Why does stroke patients usually, even though if it's a massive stroke, they'll be having a borderline GCS. They will not be unconscious. Why is that so? Stroke patient, right?
Yes, sir.
Stroke patient present with loss of consciousness.
No.
Why is that so?
Hypoglycemia patients with
loss
Yes,
of
why is that so?
the brain tissues are like brain cells are more sensitive for glucose. When deprived of that,
Which is
they can
the-
only utilize glucose
as
their
the fuel.
metabolism.
Which is a location in brain that is associated with consciousness. The reticular activating system. Reticular activating system actually arises from the brainstem and goes toward both cortex. In hypoglycemia, hyponatremia, hypoxia, and all, it's a diffuse injury. It's a diffuse thing, a generalized process. So overall reticular activation is involved, so the patient loses consciousness. Whereas in stroke, even if one cortex is affected, the reticular activating system of the other cortex is functioning. That is why the patient is not losing consciousness. Clear?
Yes.
Then the other mimicker is Todd's palsy. What is Todd's palsy?
Todd's palsy. Post
Post-seizure, there will be weakness of single limb and usually recovers after some time.
Okay. So tell me, so we know that stroke is an acute abrupt onset in disruption of blood supply, right? So can
Yes,
you name another condition where there is acute sudden onset of weakness? This stroke is a vascular cause. Another generalized cause where there is an acute sudden loss of sudden development of weakness. Means sudden onset of neurological weakness.
Unilateral weakness.
Yes, unilateral or bilateral. Sudden onset. Other than stroke.
Acute onset bilateral weakness, Guillain-Barré
syndrome
can present like that.
Guillain-Barré is actually progressive, right?
Progressive.
Sudden. Stroke is sudden, right? Stroke is sudden. Like that, sudden.
Either epidural hematomas.
Any
space occupying lesion.
Any disease, demyelination. Demyelinating disorders, because it is your myelin sheath that helps in saltatory conduction. The impulse jumps rapidly from one node of front wear to another node of front wear. So the myelin sheath is gone, the impulse conduction is lost. So one important differential is demyelinating disorders. One most common is multiple sclerosis. Okay. Then what is Hoover sign?
Hoover sign. Hoover sign.
HOOVER.
I cannot recollect. Hoover.
It's in conversion disorder, those pseudo hemiplegia. To diagnose whether it is a true or a pseudo hemiplegia. If it is a true hemiplegia, if you ask the patient to lift the affected limb, the patient, in order to lift the affected limb, the patient will be pressing the opposite limb down hard on the bed. Which will not happen in a pseudo hemiplegia. That is Hoover sign.
Okay. Yes.
Okay. So, sir.
So we'll proceed with this case. This patient, there was a M1 block, so mechanical thrombectomy, clot retrieval was done. You have thrombolized him. your BP target is okay.
Less than 180.
Yeah. Okay. Now we will maintain a BP less than 180/105, and the patient is okay. So, and another thing during thrombolysis, what you have to remember is if you are going for thrombolysis, we have to put in a Riles tube and Foley's before that.
Foley's catheter.
Yeah. If it's not, if not put, like don't put it
After the procedure.
The procedure.
yeah. Okay.
No invasive.
So I have no invasive, at least around 24 hours. Yeah. So that has been done. So you are monitoring the patient. So after 3 or 4 hours or 5 hours, you see that the patient's GCS has dropped, and his NHS score also has gone up, like by 4 or something. What is the next step?
ECS has dropped and NHS's score has worsened.
Yeah.
So my differentials at that point would be either extension of the stroke or an intracranial bleed.
So we will go ahead and we'll do a CT of the brain.
CT of the brain and rule out a bleed or extension of this.
Okay. So again, ABC first, then
ABC has to be.
so then next step is to go for a CT. Before the CT itself, send for the blood for investigations like CBC, your PTPK and coagulation, everything has to be sent, and you shift him for a CT. In the meantime, you have to like arrange for something.
Blood and blood products.
Yeah, blood and blood products specifically for
cryoprecipitate
cryo
or if available. Otherwise, FFP.
Okay, fine. So cryo, FFPs you can arrange, and you have shifted him for a CT. CT is showing a parenchymal hematoma with mass effect. So how will you proceed? So I think you will be knowing the grading of hemorrhagic transformation, right?
So petechial, it can be a parenchymal hemorrhage or a...
It's a parenchymal hemorrhage, or it can be a hemorrhagic infarct. Yeah. So one is there will be absence of your mass effect, and there will be small petechial hemorrhages, and that is within the boundary of the
30% involvement and greater than 30%.
That is in the parenchymal hematoma part. So regarding the hematoma, the HI part, that has two parts. So like it can be one or two. So one is there will be petechial hemorrhages which are around the stroke surfaces, and the other one, the type 2, there will be a confluent within the infarct regions. So these are not much problematic. The main problems comes with their parenchymal hematomas. Okay. So this patient has a large parenchymal hematoma with midline shift, and so how will you proceed?
Stabilize the airway breathing circulation.
Okay. Fine. So circulation, what is the BP target?
If it is a
it's a parenchymal bleed. So what is your BP target now?
140/90, less than 140/90.
Yeah. Okay. Many studies have gone like better to keep it below 160. Okay.
160.
Systolic, keep it below 160. There are some studies, as you told, which shows 140 is more effective, but keep it below 160. That is what most of the guidelines recommend. Okay.
Continue the neuroprotective measures. Avoid secondary brain injury.
So neuroprotective measures, like so this patient has a basically parenchymal hematoma is there with signs of midline shift is there. So he has a large ICP. So yeah, neuroprotective, how will you go?
Neurosurgery consultation.
Emergency.
Yeah, that is happening. So how will you told something regarding neuroprotection. Do you know the tier system for ICP?
Tier 0, tier 1, tier 2, and tier 3.
Please
Tier
explain.
0 is a general measures that we take, where we will maintain a saturation of more than 94%, head neutral position, head up 30 to 45 degrees,
15 to 30.
And then the carbon dioxide levels between 35 to 40, sugar levels between 140 to 180, avoid fever, avoid seizures.
Okay.
And
so next
tier Tier 1, we go to the hyperosmolar therapy plus any diversion if needed in the form of EVD. In hyperosmolar therapy, we will give 3% saline or mannitol. 3% saline, usually 5 ml per kg, targeting a sodium between 145 to 155. And if it is mannitol, 0.25 to 1 gram per kg, targeting a serum osmolarity below 320 milliosmolars. And if needed, sometimes an EVD diversion as according to the surgeons.
Patient EVD.
Hmm.
This patient EVD. This patient
No,
already
this-
has
No.
This patient is an
already has
intraparent.
Intraparent kind.
thrombolysis also, no?
Ah,
So-
yes.
Yeah.
This patient.
Okay.
So
So fine. Okay. So second tier. Okay. Then next tier.
Tier 1, Tier 2, where we go with our sedative, if needed, adequate sedation to the patient, adequate paralysis in form of muscle relaxants, and then you maintain a normothermia. And in some cases, you may give a hyperventilation to keep a PCO2 of 30 to 35.
So high sedation, paralysis required, hyperventilation. Okay. Next one.
Refractory. Refractory, in case of refractory, you may go with your barbiturate coma, you may go with the euthermia.
Hypothermia is
hypothermia.
indicated here, and then go ahead, do a
Decompression, if still there is
hypothermia of 34 to 35 degrees Celsius.
Okay. So that neuroprotective measure is going on. You inform the neurosurgeon, and BP target you mentioned. Then next thing, till they take for OT, what is the things what you will do? What all things you will do now?
So he's planned for an OT procedure.
Arrange for adequate blood and blood products.
No, you have to give something. No, the patient has been thrombolyzed with altiplase. So
Reversal of.
You'll have to reverse the intracranial hemorrhage. Maybe cryoprecipitate of 10 units to keep a fibrinogen above 150 to 200. And,
okay, so you can send for a fibrinogen. It takes time. So you give 10 units of cryo. If cryo is not available,
Tranexa.
FFP will be given if cryoprecipitate is not available. 10 units. If platelet is less than 1 lakh, 6 to 8 units of platelet.
Tranexamic acid may be given one.
Wait. Regarding this thing, what will you give? You are given FFPs, you are given cryo. If cryo is not available, cryo won't be normally available. You can try FFPs or something else you can give.
Oh, thrombin complex concentrates, PCC.
PCC can be given, or fibrinogen you can give, no? Fibrinogen you can give. Okay. Then, so after that, you can give FFPs, everything. Okay. Then, Russell, then next thing you told is
tranexamic acid 15 to 20 mg, followed by 1 gram infusion.
Yeah, 1 gram. Okay, 1 gram you can give.
Over 8 hours.
How does it work?
Antifibrinolytic agent.
So how it prevents the conversion of plasminogen to plasmin. So prevents the FTP, like prevents the breakdown of fibrin. Okay, fine. So and you take him up for a neurosurgical procedure.
Yes, sir.
Yes, sir.
What is the evidence for the same?
Destiny,
Hamlet, Destiny, Decimal and Hamlet for malignant MCA infarct. They showed that there is improved mortality, but no much improvement in the functional outputs. Sir,
Okay, so okay, fine. So you will go for a decompressive craniectomy. Once all the procedures fail, you can go for this thing. The evidence you told is okay. Then only I think you can proceed now. Yeah, they will go for the next slides in the theoretical part.
Sir, you are on mute, sir.
Oh, okay. I'm modifying the scenario a bit. This patient actually went to bed at 10 p.m. at night and presented with stroke at 10 a.m. the next morning. Presented with a wake-up stroke. How will you proceed with regards to imaging?
According to the wake-up trial, you can take an MRI and you can look for the diffusion flare mismatch. if there is a diffusion flare mismatch, which means it's a hyperacute stroke. And according to the wake-up trial, it has shown better functional outcomes.
Okay, when will the MRI appear hyperintense on diffusion weighted MRI sequence? At what time? If you're going only for a diffusion weighted image,
less than 6 hours.
Diffusion, it picks up immediately within 30 minutes. Flare?
Diffusion is faster. Yeah. So always for MRI, don't go for the complete MRI. You go for the diffusion and flare.
No need to do for the complete MRI brain protocol. You just need to do the diffusion flare. And in the flare sequence, you can have the
diffusion flare mismatch. If it is not appeared in the flare, which means that the stroke is less than 4.5 hours, can be considered as.
In the flare, you can go for ADC. What is ADC?
Apparent diffusion coefficient to differentiate between cytotoxic and vasogenic edema.
Okay. So you can say the stroke is less than 4 hours and you can go for thrombolysis. So any other advanced imaging that you know?
Perfusion, CT perfusion imaging.
Okay, what is that? Why do you want to do a CT perfusion image?
CT perfusion also helps us to visualize
how much area is
the salvageable penumbra.
Okay. So that helps you in identifying the core, how much volume of core is there.
Volume of core.
There. Penumbra is also there. So different penumbra, what is ischemic penumbra? What is penumbra?
That part of the brain where the blood flow is less and it is temporarily non-functioning, but our aim would be to recanalize so that that area is saved.
Yes, the cerebral blood flow is too low to maintain the electrical activity, but sufficient enough to maintain membrane integrity. The intactness is still left. What is the core? Define core.
Core is the area of the brain to which there is loss of blood flow.
Yes, there is total
absence of electrical as well as membrane activity.
Yes, ionic pump failure ultimately leading to cell death.
Death has already occurred.
Okay. So there any newer advances that you know? Newer advances with regards to MRI. You already mentioned the diffusion weighted flare, the ADC sequence on flare, CT perfusion. Any newer advances?
GRE, gradient echo.
GRE newer.
There you have the arterial spin labeling MRI. That will help you in identifying the collateral status. Maybe you can thrombolyze up to 9 hours. That's what they say. That is one of the recent advances. Sujit sir.
Nothing. We can proceed, I think. Yeah. Next.
I think, can you go? I think we have summarized a bit in the upcoming slides. Can you go to the next slide? So a bit about the pre-hospital scoring. Any pre-hospital scoring systems that you know?
Cincinnati, Los Angeles.
Yes, the Reusser is also there. Cincinnati is mainly the fast. And the Reusser?
Speech time.
Speech time.
Yes. Then the NIHSS, we mentioned the NIHS, it's a bit complex to learn, but you should need to know. The stroke mimics we discussed. And next slide, please. Okay, next slide. More than 22, the risk of ICH is much high. And you can remember in these NIHSS in these headings, mental status changes, cranial nerves and limbs.
Yes.
Next slide. So main goal of neuroimaging is to rule out a hemorrhage and exclude stroke mimics, assess the location, degree of brain injury, plus or minus a CT angio protocol to identify the occluded vessel. Next slide. These are the earliest signs. Once 12 hours have progressed, the CT will show a hypodensity on the image where you should not be thrombolizing it. Next slide. This is the aspect score. Aspect score less than 6 carries a poor prognosis. There are 10 points allotted at cortical and subcortical areas. Next slide. Already mentioned. Next slide. This is a diffusion weighted MRI. If you are quick enough, you can go for an MRI for this patient also, because it carries high sensitivity specificity for detecting infarcted regions even very early, within minutes of symptom onset. Next slide. This is what is this image? What is this image?
Perfusion.
You already mentioned.
Perfusion imaging.
Perfusion imaging, where you can, what are the parameters that are being assessed with it perfusion imaging? What is MTT?
Time to mean transit time.
Yes, in an ischemic penumbra, the mean transit time will be increased, the cerebral blood flow will be reduced, and cerebral blood volume will be normal or increased. Next slide. So how will you assess for the presence of collaterals? That is where you need to do an angiography. Next slide. Next slide. Already discussed, you can detect large vessel occlusions. And MRI, the advantage of MRI is you can detect other less common causes of ischemic strokes like arterial dissection, fibromuscular dysplasia, CVT, or some causes of vasculitis. Next slide. CT angio. CT angio, the disadvantage is it provides only a static image of the vascular anatomy. It is inferior to DSA for the demonstration of flow rates and direction. Otherwise, it is highly specific and sensitive with a positive predictive value nearing 100%. Next slide. So these are the conclusions we already mentioned. Next slide. Next. This already mentioned. The arterial spin labeling MRI is a newer advance that helps in the identification of collaterals. Next one. It's a flow chart of neuroimaging. Acute stroke, within the first 6 hours, go for a conventional non-contrast CT. If there is a hemorrhage, no therapy. If there is no hemorrhage, if it is within the first 3 hours, proceed with IV thrombolysis. And if 3 to 6 hours, go for an angiogram study. And if there is a thrombus with penumbra, consider intra-arterial therapy, and no penumbra plus or minus thrombus, it may not be useful. Next slide. So the timelines you already mentioned. Next slide. Timelines. Next slide. I think, sir, we have discussed all these slides. I just kept all these in the slides also, all the trials and all. Shall we conclude, sir? Anything you want to add, Dr. Shalini and Dr. Anubhav?
I think just go to the this thing studies slide.
Yes.
Yeah, before that, one more thing we missed is you were told regarding that ICP monitoring part. You had told regarding including EVD and ICP measurement. So, like non-invasive techniques for ICP.
Clinical assessment.
Okay.
Then transcranial Doppler,
optic nerve sheath
diameter. Sir, you can.
We cannot hear yours. So you're muted.
Okay, so for clinical, okay, and main thing you have to look is TCD and also
optic nerve sheath diameter.
Diameter. Okay, which is less invasive.
Yes.
Okay. Can we go to that these slides that our studies?
Yes. Can you brush through the slides fast? Yes. Stop. This is the evidence regards to intra-arterial thrombectomy. Mercy trial achieved recanalization was achieved in 46% of the cases versus 18%. Next slide. The Penumbra pivotal stroke trial in 2000, published in 2009, showed spontaneous intracranial hemorrhage was 11.2% with a mortality of 32.8%. These are all first generation devices. This Mercy trial and Penumbra was done with the aid of first generation devices where there are no much functional outcome benefits were attained. Then came the trials with regards to second generation devices, which are Solitaire and Trevo. Next slide. These are the trials that was done primarily with first generation mechanical thrombectomy. You could see in the synthesis IMS3 and this last one, there is no significant difference in outcomes. Next slide. These are the second generation devices where you can, the stent will help in retrieving the clot, Solitaire and Trevo. Next slide. So you could see this is comparing the successful recanalization without symptomatic intracranial hemorrhage. It was 61% with Solitaire compared to 24% which was with Mercy. This was published in Lancet in the year 2012. Okay. Next slide. So these are the studies that was done with the second generation devices, mainly the primarily stent retrievers. So there is no significant differences in mortality and spontaneous intracranial hemorrhage. And in the last SWIFT trial, recanalization was observed in nearly 88% of the patients. Next slide. These are the other trials, Revascat and Extend 1A trial. Good recanalization rates were obtained favoring timely endovascular therapy. So that's the importance of referring to a center with IR services. Next slide. So these are the positive trials, Mr. Clean, Extend IA, Escape, Swift Prime, and Revascat. Whereas IMS3 synthesis and Mr. Rescue use the first generation. These are the negative trials. Next slide. So these are the recent evidence on DAWN and diffuse 3 already mentioned. Treatment can be done beneficial if within 6 to 24 hours for DAWN and 6 to 16 hours for diffuse 3. Next slide. So to conclude, patients eligible for intravenous thrombosis should receive it even if endovascular therapy is being considered. Even if there is a clot identified on the angiogram, you should consider intravenous thrombolysis to soften the clot, so that it could be easily retrieved with a stent. Degree and time of recanalization are better with endovascular thrombosis rather than with intravascular endovascular therapy than with intravascular thrombolysis. And newer generations already mentioned, tissue-based time window can be extended up to 6 to 24 hours in patients who meets the criteria, DAWN and diffuse 3. Next slide. So these are the timings. Next slide. Okay, so what are the predictors that the patient could develop a malignant MC infarct? This is a malignant MC infarction. What are the predictors for the same?
PT showing more than 50% of the MCA involvement. Perfusion imaging more than 66%.
Yes.
In an MRI, within 6 hours, if there is 82 ml of the infarct volume, and in 14 hours, 145 ml of the infarct.
Yes, correct. Next slide. Already mentioned. Okay, next slide. Showing the evidence of decompressive. Next slide. Evidence of decompressive craniectomy in malignant MCA stroke. The decimal destiny Hamlet showing a clear mortality benefit, but no major improvement in functional outcomes. Okay, I think next slide. This is the last slide, I think. So these are the lessons learned. Important predictors of successful recanalization ischemic stroke include the site of occlusion we should be knowing, age and composition of the thrombus, presence of effective collateral circulation can be assessed by the appropriate timely imaging, the timing of thrombolysis, intra-arterial versus intravenous, the combining how to combine endovascular with intravenous thrombolysis, which needs technical expertise and infrastructure. Okay, this is the last slide. Anything you want to add?
Before concluding, one more thing regarding your normal ICU management. If somebody has a hemorrhagic transformation, when will you start your DVT prophylaxis? You can put in a IPC, but when can you start a DVT prophylaxis?
DVT prophylaxis, generally, if there is no hemorrhagic transformation,
No,
we
if there
generally
is
start
hemorrhagic
with,
transformation,
if
if
there
this
is,
patient, if you have undergone a this thing, decompressive craniectomy for a hemorrhagic transformation, so when can you?
heparin for DVT prophylaxis.
Yeah. You can put in always a IPC.
Yes,
The
sir.
evidence both are equal. That is okay. But still, if you want to start heparin, then can you start? You repeat your imaging, see if there is no bleed or something. It depends, but normally, like up to 4 to 5 days, you can wait and then start off.
Yes.
Okay, then same thing regarding your embolic stroke. If the embolic stroke, if the patient has a AF and patient develops a stroke, and when can you start your anticoagulation?
So if it is a minor stroke,
minor to moderate, 4 days. And if it's a severe stroke, 7 days.
There has been trials which has compared delayed as well as late oral anticoagulation for the patient, like anticoagulation, and the favor is in more of
a early interval.
So if minor, in 3 to 4 days.
3 to 4 days.
Severe stroke, 7 days.
Yeah, minor you can give up to like 4 days, and in severe 1 week or maybe 2 weeks, depending on your clinical situation. Yeah.
Yes.
So anticoagulation required. Then regarding your TAA, so TAA, as you told, like as per the ABCD2, you can grade them. If it is a low risk patient, won't require any admission or anything. You can discharge him on OP basis, but you need to start at least single antiplatelet and statin.
Yes.
What is the definitive treatment for this TIA? If it is a carotid atherosclerosis.
High risk, yeah, especially high risk. Yeah. If it is high risk, as per the present studies, I think chance and inspire. So as per the studies, you have to give a dual antiplatelet. You load with cloplet 300 and aspirin like around 50 to 100. Yeah, 21 days. So you can combine for 21 days, and they showed, like, it is a Chinese studies which showed that the stroke
Bleeding
progression
was also less.
Yeah, the stroke progression was less. And 90 days stroke progression was less compared to the placebo group. Okay.
And a definitive therapy for TIA. These are medications, no? Definitive therapy.
Stenting.
Better than stenting. Carotid stenting.
Thrombectomy.
Carotid endarterectomy. Carotid endarterectomy is better than carotid stenting.
Yes.
In which patients you will prefer carotid stenting before carotid endarterectomy? Which patients? In high risk cardiac patients, high risk cardiac cases, carotid endarterectomy is not preferred. Okay. So after thrombolysis, what all medications you will add for that patient in the next 24 hours?
We'll start him on dual antiplatelets and
first 24 hours. First 24 hours.
Avoid after thrombolysis, avoid for the first 24 hours, and then after 24 hours, you can start them on.
First 24 hours, no other medication.
No other medication. Okay.
What is the role of anti-epileptics?
No
prophylactic antiepileptics.
What is the role of anti-edema?
No role for
proven role for anti-edema.
Anti-edema measures.
When will you repeat a CT?
After 24 hours of thrombolysis, or if there is
any GCS drop or
greater than 4.
Which is increased.
Only 3 indications where we will consider dual antiplatelet therapy in stroke. I think Sir already mentioned. Only 3 indications. Actually, only single antiplatelet is recommended after 24 hours. Only 3.
High risk
TIA.
Cardioembolic
stroke.
Intracranial atherosclerotic disease, ICAD. Cranial, and if there is corresponding cardiac disease also, you need to initiate on DAPT.
Anything you like to add on? The slides, I think, will be shared in your group. So anything else you want to add on? or any questions.
Yes, sir.
Yeah, we are done, sir. I think, thank you very much, sir. It's been a very long marathon. I think close to about 1 hour and 40 minutes. I think we had a seriously good number of audience today, almost nearing about 100, including YouTube. So that was a peak number we have almost achieved. So I hope most students who have joined would have got benefited. So I once again take this opportunity to thank Dr. Sujit as well as Dr. Unikrishnan for their valuable time spent with the students. I also thank both the examinees too, Dr. Solini and Amy Thomas, for their time. So I hope all the students will get benefited, and still we would be happy to upload it in YouTube by Monday. So we request you to access for any future references for the YouTube. So have a nice weekend. Wish you all best of luck for your examination once again. And looking forward to meet you in the next week Saturday class once again with a different topic and different examiners. So thank you very much once again, Dr. Sujit and Dr. Unikrishnan, for your valuable time. Thank you very much.
Thank you,
Good
sir.
night, sir.
Thank you, Sujit sir. Thank you, Unikrishnan sir.
Thank you.
Yes.
Thank you. All the best for your exams. Thank you.
Thank you, sir.
We can close, sir. Thank you, sir.
Thank you, Prashant. Thank you for both of them. Had a nice session.
Somebody can pause it now.